Good morning, everyone. Thank you very much, the chairpersons and to the organizers for this kind of invitation. It is my pleasure to be here again, also this year. The topic now will slightly change because I'm a pathologist and therefore I will shortly, I can use this one, thank you. I will shortly address some challenges for our pathological diagnosis of cancer, sticking on the topic of lung carcinoma. This is the list of issues which we daily face in our work. Of course, the first yellow box is the cytology, a small biopsy, small specimen, which are the most common specimens which we receive in the laboratory. Of course, sometimes there are surgical specimens. Rarely lung cancer can be operated on, and there are additional questions. I will try to shortly summarize some of these issues. First of all, morphology, subtyping, grading, regular microscope work, which has not yet been replaced by any deep learning, artificial into anything. Maybe in the future, but I'm going to retire, so I will not see it. So for the time, we have to use the microscope and try to provide the name and possibly the surname or possibly the nickname of different lung cancers according to the WHO classification, which is listed in this, which is listed in this slide, including non-small cell lung cancers on the one side and neuroendocrine tumors on the other. These things have not changed. The names have not changed. There are minor modifications, especially based on molecular diagnostics, because new subtypes and special types are upcoming. They are fortunately or unfortunately very rare, but we have to recognize them because, of course, our medical oncologists and friends want to know everything about a given lung cancer. Regarding the common pulmonary carcinoma type, of course, we have to recognize squamous carcinoma. There is a ISLC grading project ongoing, which I have the privilege to participate into. So in a short time, you will have a new proposal on the grading of squamous carcinoma, which is an additional feature requested for the purpose of better classifying these tumors, exactly as it is ongoing for adenocarcinoma. You know, the knowledge on adenocarcinoma is much larger. They are the most common type at this time in the lung carcinoma. What we have to do as pathologists is to distinguish these two groups, the green group in situ cancer and the red group invasive adenocarcinoma. This is crucial because, as you know, early diagnosis brings to the recognition of many early stage cases, and many of them are in situ, and sometimes the recognition of invasion is a hard task. And if we call invasive an adenocarcinoma which is not invasive, we actually provide an additional exaggerated treatment to the patient, and this is the reason for having a very nice survival, because sometimes pathologists call invasive what is not invasive, and of course in situ adenocarcinoma has 100% survival. So for example, this is a project which I have the privilege to participate into with Dr. Tunissen in Holland. The study is called the resin study. I mean, I call it resin study because there is a difference between grape. Did you see here these big grapes that are in privates? Okay, those are fresh fruits, but if you use resin, those are dried resins. And this is the pattern which we have to recognize in order to assess invasion in adenocarcinoma, because the lung is full of air. And when you receive a specimen after surgery, the lung is collapsed. And when the lung is collapsed, if there is a cancer inside, sometimes the in situ growth along the alveolar walls looks like invasion. So that's the big problem for us. So this is one of the main challenges we have in our daily work. Call invasive what is not invasive, and provide suggestion which is completely destroying the regular regimen, therapeutic regimen. So this is what we do, and we use markers. So cytokeratin 7 and elastic staining are very useful to recognize the previous regular pulmonary pattern, even in collapse lung after surgery. So this is just one of the challenges. An additional challenge is how to grade tumor. I mean, to answer the question, how is the differentiation level? Very similar to regular lung or very different, very poorly differentiated? And we have several rules, which for the adenocarcinoma are well set now, with a cutoff 20% of high-grade patterns necessarily recognized within each individual lung cancer which is resected. And we hope to provide a similar proposal for squamous carcinoma soon. An additional challenge is what to do with poorly differentiated carcinomas. The so-called large cell or anaplastic large cell carcinoma is a disappearing entity because these three colored box include squamous adenocarcinoma and neuroendocrine carcinomas. The undifferentiated lung cancers must eventually be classified within one of these colored boxes. So if we are unable to decide, we face very rare undifferentiated tumor which belong to the so-called null phenotype, in which we are unable to identify any marker pointing to a given differentiation lineage, which is the one which you oncologists need to know in order to define the most appropriate treatment. Of course, there is a molecular approach which can help to subclassify these undifferentiated tumors, but this is not available on a daily basis, so that it is very difficult for us in my laboratory to have molecular tests done in order to provide the molecular classification for these tumors. But there is some possibility of actually recognizing as an adenocarcinoma or the squamous carcinoma those cases which are completely undifferentiated. Regarding neuroendocrine neoplasms, the same challenges occur because we have rare, well-differentiated tumors called carcinoids in the lung, and we have high-grade, very poor differentiated neuroendocrine carcinomas called small cell lung cancer or large cell neuroendocrine carcinomas. And actually, and unfortunately, those different groups of neuroendocrine tumors, as you can see in these slides, are represented as different circles, white and gray and black circles, and there is some overlap between them. And therefore, even our diagnostic capability sometimes is challenged by the fact that some features are overlapping, and therefore we unfortunately are unable to provide you oncologists or clinical doctors with clear-cut benign diagnosis like low-grade diagnosis like carcinoid versus high-grade small cell lung cancer, because the overlap is sometimes occurring and biomarkers are not very helpful. Finally, we have combined tumors. They are rare, but they do exist. And the combined tumors are a problem for two reasons. Reason number one, if you receive a small specimen, you don't know where the radiologist or the pulmonologist has taken the specimen. Could be in the neuroendocrine area or in the non-neuroendocrine area. Challenge number one. Challenge number two, even worse for us, is that if you have a patient undergoing rebiopsy after treatment, sometimes an adenocarcinoma with EGFR mutation, for example, develops progression towards small cell lung cancer. Maintaining the molecular profile of EGFR mutation, but acquiring additional neuroendocrine typical alterations or RB1 or P50, whatever, so that in rebiopsy we may face a tumor with neuroendocrine features developed from an adenocarcinoma, for example. Therefore, combined tumors do exist. Regarding staging, there is the new 9 edition of the TNM with minor modification in the lung. I will not spend time on that. Keep in mind that sometimes you will see a discrepancy between the TNM staging system edition 8 versus edition 9, because, for example, the N2 condition, like here in the bottom right of the slide, there will be a differentiation in type 2A and 2B based on the number of lymph nodes, which will make additional minor changes. And in the future, there will be an additional role of morphological parameters like STAS, which is spread through alveolar spaces, which is a sort of microinvasion in alveolar, normal alveoli around the tumor, which will be now included in the staging system rather than in the morphological definition. An additional point and challenge for us is to assess pathological response, which means an inoperable tumor undergoing neoadjuvant treatment for subsequently resected. So we receive a tumor, hopefully completely necrotic, if neoadjuvant treatment has gone okay, but we have to decide which type of response has been identified, if any, and if it is complete or not. Therefore, there are different rules by which we have to assess either the primary tumor or the lymph nodes or both. And there are different rules according to the ISLC or the immune-related pathological response criteria, the so-called IRPRC, and so on. In one word, what we have to do is to check the tumor, cut all the specimen, which if it is a 10 centimeter tumor means that we have to prepare maybe 50 slides for one case. So it is huge work. And then to define whether the tumor is alive or is dead, if there are viable cells or not. So this is the real life left part. This is a tumor with the central cystic excavated, many blocks, many slides. We have to make a percentage of the viable tumor cells versus the non-viable tumor area, summarizing this colored graph here, in which you have the so-called tumor bed, which is the idea of where it was the tumor before the very effective treatment you gave. So the tumor was the green area. How much surviving tumor cells exist? 0, complete response. Less than 10%, major response. More than 10%, almost poor response or no response. So this is what we have to do. And we must be very accurate in counting this. And to be accurate, we have to check all the tumor that has been resected. So for us, it's a very bad problem. There are additional ways of checking response, not only with the microscope, but also with markers like PGL1 expression, or even with molecular data like tumor burden. And there are several papers. I mentioned one from a Chinese group, Dr. Wang, but many Chinese are called Wang, so we have to check for the proper paper, Frontier of Oncology 2024, the end last year. And this Dr. Wang has also proposed a sort of nomogram, including several parameters to better assess response, because viable cell percentage may not be the only parameter. We may need to add some others like PGA1 and radiological response and so on and so on. And so. Regarding small specimens, I have already discussed with you in Bulgaria many times this issue last year, because if you ask me which are the challenges, our challenges are always the same. We try to improve, but the path is very long. So with regard to small specimen, what we have to do is, number one, spare tissue. Don't use it for your markers, because the following week, Professor Managal or Dr. Balikova will call us, please go ahead with molecular, and we have finished the small specimen. So either the sample is larger or we have to spare tissue. And the second issue is the one. So I am allowed, and I allow my co-workers to use 2 markers only, one for adenocarcinoma, TTA1, and one for squamous carcinoma, P40. If there is a suspicion of neuroendocrine, I allow the third marker, which could be, at this time, in SM1, which is the best transcription factor, or chromogranin if you prefer. So after these 3 markers, we have to give up and put the material in the file, because you don't know next week what can happen with our oncologist. So we have to spare tissue. If the solution with the markers is okay, we report the case as favor adeno, favor squamous, favor neuroendocrine carcinoma. If we fail, we report as null phenotype or non-conclusive immunophenotype, and the case remains an undifferentiated lung cancer. Hopefully not a metastasis, because we never know. So with immunohistochemistry, we have this diagnostic protocol with the 2 or 3 markers at most. Then we have prognostic markers, usually Ki67, but nothing more. And of course, we have to keep material saved for the predictive marker assessment, which can go either directly with NGS molecular tests, or can be a combined approach. For example, we test immunoalk and immuno-PDL1 and other markers are done with the molecular tests. In the end, we have to report the small specimen following the WHO classification. As you are informed, couple of years ago, a new series of WHO blue books have been established of cytology diagnosis, not the histology classification, but cytology. And the first book has been lung, cytopathology of the lung, and therefore there are lists and there are rules for this classification. An additional challenge, I go on fast because I want to point out issues rather than solving issues, because I'm not here to solve problems, unfortunately. And an additional issue is related to molecular classification. My personal view as an old pathologist is that morphology comes first. So issue number one is to look at the microscope. Issue number two is provide molecular tests as much as possible according to the requirements of our oncologist. We do not do any reflex test. We wait for our medical oncologist to ask the test and exactly which one do they want. You know that there are several options. This is the summary of the last 20 years in which molecular tests have been extensively validated and established, and many of them are associated to a specific therapeutic option. Some others are still under investigation. In the end, if you can use the NGS system, you can test a large panel of genes. If you want to go with directly PCR tests for single or few gene testing, you can do as well. Sometimes there are the opportunity of making predictive immunohistochemistry, which means ALK, ROS1, for example, can be tested preliminarily by immunohistochemistry, but any lab can set their own ideal option for the work. The only problem is provide that you use a tissue which contains viable tumor cells. I don't need the number of cells. I need a minimum sufficient number, irrespective of the type of material. Based on the major pathological response issue, remember that sometimes a small biopsy is better than a surgical specimen, because if the surgical specimen is all necrotic, you cannot do any test. And the small biopsy could be better. There are several oncogenic drivers. I don't want to spend time on that. We have different approaches on that. And the molecular tests sometimes help to align our classification, adding to the microscope classification a sort of molecular classification, because the different types of tumors, for example, adenocarcinomas, have different genes associated to their types. For example, solid or signet ring adenocarcinoma has many more ALK and ROS1 changes than the others. And in situ lipidic adenocarcinoma in situ do not have much tumor burden as the high-grade adenocarcinoma. Therefore, molecular tests are to be studied in parallel with morphology. Of course, there are additional information. I take the opportunity of presenting this study, came out last week, a couple of weeks ago, in a big journal like Nature Medicine, in which the molecular informations that can be drained on a metastasis, for example, brain metastasis from lung cancer, can show why a lung cancer goes to brain rather than to bone, rather than to adrenal gland or wherever, because these tumor cells are able to reactivate a sort of genetic program that prepare the tropism towards brain rather than bone, rather than adrenal. For example, this nice study from a couple of weeks ago in Nature states that the cells have a neural-like program that helps tumor cells from the lung to find their way to the brain. And so this, let me say, basic science information can be useful in the future for a medical oncologist to identify specific options to stop some genetic program and exclude or fight against the possibility of developing brain metastasis. The same problem with molecular data occurs in the area of small cell lung cancer. It is very clear now for at least 4 years that small cell lung cancer is one microscopic type made of small cells. Easy for us. But is a heterogeneous molecular type of tumor because there are at least 4 molecular subtypes, and not all of them are neuroendocrine, only type A and type N. And there are another 15% of cases which look like small cell lung cancer, but they are not neuroendocrine, and they are those that do not respond that much to the classical platinum etoposide treatment, and rather they can take advantage from immunotherapy protocols, especially the 4th type, which I call triple negative. I mean, the one missing the 3 classical genes because they do not express, and they have a sort of environment associated to an inflamed condition, inflammation, so it's called inflamed triple negative because of this particular pattern. Apart from these 4 types, there are additional very rare types published last year in which small cell lung cancer sometimes is actually having alteration of the gene SMARCA4A, so it is a SMARCA4A deficient tumor. Even if it looks like a small cell lung cancer, it's not, it's a SMARCA4 deficient. Another one has retinoblastoma 1 gene wild type preserved, and this is another special type affecting young people. And therefore, within the so-called small cell carcinoma area, there are very many different types. Exactly, if you allow me to jump, exactly as what happened in the small cell blue tumors of infancy, which are small cell blue tumors, but they include Ewing, neuroblastoma, PNET, many others. And so it looks like the small cell lung cancer is going in the future to be something else in terms of classification. So this is the summary. Green area, 4 types of small cell lung cancer. Blue area, 2 types of large cell neuroendocrine carcinomas. Gray area, 3 types of carcinoids. At least 3 types of carcinoids. In the afternoon, we will discuss these carcinoids in case. So a final issue is what to do with molecular type, when is to be done. There is the option of reflex testing or acting upon request. There is an additional question regarding liquid biopsy. Why don't we do liquid biopsy and forget about tissue? So this is a difficult question. Of course, as a pathologist, I like to test the tissues, of course, but I'm prone and I'm ready to change my opinion if they demonstrate that liquid biopsy blood is identical to tissue in order to identify all possible changes without contaminations, because from the blood you can collect circulating free DNA from many other areas, including many other tumors, and you never know whether the patient has 1 tumor or many more tumors. So that's the issue of liquid biopsy. But in the future, liquid biopsy is something very, very powerful, provided that we use the same preservation conditions as those used for tissues, because blood cannot be taken everywhere without an appropriate transport and preservation and transportation condition, because the RNA and the circulating free DNA is very delicate. The same holds true for immunohistochemistry. I already presented it last year, and we still go ahead with some immunohistochemistry in order to predict the expression of ALK, ROS1, and few others. In the end of molecular tests, we include PD-L1 because PD-L1 is very popular and is going to be expanded in many other areas out of the thoracic area, although the need of the pathological assessment of PD-L1 is not the rule. Some cases do not need PD-L1 assessment by pathologists for deciding the treatment. And in other areas like breast, there are different conditions, different antibody, different target cells to be measured, like lymphocytes and macrophages in addition to tumor cells. And therefore, the regulation for interpreting PD-L1 expression is different in each individual tumor areas, which for a general pathologist, as we are, is sometimes complicated and difficult. Since we are behind the time, I'm trying to hurry up, and I want to finish with a couple of comments on the options of cancer reporting. I already mentioned that there are indications in the WHO for small specimen and especially cytopathology reporting. in which there are rules similar to breast or thyroid or salivary glands, in which there are different subgroups of options in which we identify benign or, thank you, benign or suspected malignant or malignant lesions. This has already also been proposed by the WHO for lung tumors, and each category is associated to a different ROM, risk of malignancy, as occurs in the breast and in the thyroid. Therefore, we can somehow predict the level of certainty in our cytological diagnosis. With regard to surgical specimens, there are indications from the different entities, including the ICCR reporting system, in which they teach us how to report not only morphology, which is easy, but especially molecular data, because we need to interpret molecular data in a reproducible way, because many laboratories, they use different systems or test different gene panels, and so we have indication on the reporting. Of course, everything can work perfectly with a final accurate report if we start with the correct approach. You see, I follow the reverse way, because I'm finishing with the handling of tissue, which should be a general issue at the very beginning, but now times have been over. This is our technician coming some 15 years ago from the surgical room theaters with this trolley with all the specimens under the sun, 35 degrees in June and July. And so the preservation of the tissue is somewhat a problem, and formalin is going to evaporate everywhere. So the hospital was full of formalin. Now our hospital is formalin free. Specimens come under vacuum, fresh, but under vacuum, transported within the refrigerated box, you see, like the one for the summertime, I mean for vacations. And the tissues are put in formalin only in our laboratory under strict conditions, fixed for 24 hours and then processed. So this is what we have to do. So we have a sort of strict rules for the managing and handling of tissues, and this is the European rules published last year by the Committee of the European Society of Pathology in order to have a reproducible approach. I have additional information regarding the cost of diagnosis, but this can be discussed with some of you in case of interest. Our administrators, usually, at least in Italy, because of the crisis, do not want to buy anything, any new equipment, never update. We took the liberty of calculating how much was the cost of a diagnosis of lung cancer, starting from the biopsy until the resection specimen. And we found actually an analysis, very detailed analysis of the different reagents, costs, slides, personnel, and everything. And we ended up with an impressive cost. So it is 500 per patient, the biopsy, and over the 1,000 euros for the complete diagnosis, including the markers and everything. So we do not cost as much as the oncologists for the treatments, because some special target treatment is very expensive, but we do cost quite enough, because our tests are expensive and require additional examinations which go over the glass slide, which is less than €1, and the regular standard stain, which is 15 cents. Now the molecular tests and the immunohistochemical tests are very much expensive. So in the future, what can we do? Replace the pathologist with the machine. This is what everyone wants, because they don't like us, and so they prefer a machine, because the machine never claims never cries, you see, the machine. So the future is okay. I think that in the future there will be the chance of subtyping some easy cases. So adenocarcinoma, squamous, neuroendocrine, like that. Some prognostic markers can be counted by the machine, PDL1, Ki67, these things can be done. Rare tumors, no. And eventually the machine will not be able upfront to decide if the tissue is okay or not, if it is viable cells or not. So we need a sort of pre-pathologist, something like this, checking if the tissue is containing viable cells or is necrosis, fibrosis, inadequate like that. And then if you want, you can stop the role of pathologist and put everything into a machine. But the original selection of the tissue still needs a human being. That's it. So I don't want to comment on the prediction of these things, but there are very many published reports on the different roles of deep learning algorithm, not only in screening the markers, but also on the screening of the different histological types. Let me conclude with one example. Paul Hoffman in Nice, France, has done a very beautiful study in which is this one. No, it's not this one. Anyway, in which he taught the machine to classify neuroendocrine tumors. The machine was perfect. Where was the problem? That since the machine was taught to recognize small cell lung cancer based on the crushing artifact of the small cells one together with the other, if you have a large cell neuroendocrine carcinoma or a carcinoid, which due to the surgery has been suffering some crushing artifact on the border, the machine calls small cell lung cancer a carcinoid, which if it was my tumor, I would not be happy of that. So the machine is okay, but please check it. Thank you so much.